everyone to today's webinar, Payer-Provider Collaboration, How Prisma Health and Blue Cross Blue Shield Vermont Transformed Risk Adjustment. On behalf of Becker's Healthcare and today's sponsor, InvoCar, thank you for joining us. My name is Alexis Kaiser with Becker's Healthcare, and I wanted to walk through a few quick housekeeping instructions before we begin. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We will have a series of poll questions during today's webinar. You can submit the answer that best applies to you directly on your screen in the slides box. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you do not see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box. As always, we are here to help. With that, I am pleased to welcome today's speakers, Dr. Anil Jain, Dr. Andrew Albano, and Charlie Booten. Dr. Jain is currently Chief Innovation Officer at Innovaccer. Previously, he served as Chief Health Information Officer at IBM Watson Health, was co-founder and Chief Medical Officer of Exploris Incorporated, and Senior IT Executive and attending physician at the Cleveland Clinic. He has served on numerous regional and national committees, including the HHS and ONC Federal Health IT Advisory Committee, set up by the Cures Act to focus on interoperability. And he was a member of ONC's Intersection of Clinical and Administrative Data Task Force. Dr. Albano currently serves as the Chief Medical Officer for Population Health Management of the Invio Health Network, a more than 5,000 provider clinically integrated network, and as the Quality Officer for Primary Care at Prisma Health in South Carolina. Additionally, he is an Associate Professor at the University of South Carolina School of Medicine in Greenville, and further contributes to the healthcare industry by serving as a board advisor for several health tech companies. Charlie Booten currently serves as the Manager of Risk Adjustment Programs at Blue Cross and Blue Shield of Vermont. He is a results-driven senior executive with extensive experience, primarily in the healthcare industry, and has demonstrated success in achieving revenue and business growth objectives within highly competitive and rapidly changing marketplaces. His extensive experience is as a corporate financial analyst, strategist, planner, and operations manager, with demonstrated results in leading sustainable productivity improvements through rigorous process improvement, while enhancing internal and external customer satisfaction levels. He is a proven problem solver who has created new departments, functions, and processes that have been and still are highly successful. Organizations from startups to 6 Fortune 100 companies have benefited from Charlie's expertise. The types of industries these organizations are in range from government, payers and providers, to healthcare vendors and consultants. Lastly, our moderator for today's session, Roxana Cross. Roxana Cross is currently a Director of Product Management at Innovaccer. Her focus is on interoperability, risk adjustment, quality, and solutions that enable digital transformation across the payer and provider value chain. Previously, she held senior leadership positions at Blue Health Intelligence, Basis, WellPoint, General Dynamics, and VIP. Roxana is a seasoned product management professional with substantial health IT experience. Thank you all for being here today, and I will now pass the floor over to our moderator, Roxana, to kick off today's discussion.
Very good. Well, thank you, and hi, everyone, and welcome, and thank you for joining. And today we have 3 exceptional people with us who will be sharing their insights. And now that you've been introduced to our 3 panel participants, I'd like to take a moment and find a little bit more about who's attending today. And so I'd like to begin with a brief getting to know you polling question. So if you could take a moment and let us know the type of organization you're part of, we would appreciate that. Is it a provider organization, payer health plan, vendor, consultant, or other? So we appreciate it. Okay. Oh, we have a lot of provider organizations represented here today. Very good. Well, wonderful. Okay. Well, thank you very much. Okay. So our topic today is payer and provider collaboration around risk adjustment. And if you've been in the industry as long as I have, you will remember the start of risk adjustment back in 1997 as part of the Balanced Budget Act for Medicare Advantage. And here we are, 25 years later, and risk adjustment is being used to meet three very important goals in our industry. Number one being, to help make sure health plans and doctors are paid fairly for the people they care for, to lessen or eliminate the influence of risk selection on premiums and the incentive for plans to avoid enrolling sicker enrollees, particularly people who are seeking individual and small group coverage, and to help ensure individuals have their health needs comprehensively understood, addressed, and documented so we can better manage care and we can better align benefits and services with health needs. So I think we all agree these are very worthy goals. And to meet these goals, risk adjustment uses a methodology that equates an individual's health status with a number. And that number is called the risk score. And the risk score really is the star player in risk adjustment. It is used to predict healthcare cost, and it is used to determine how health insurers and health plans get paid for the services they provide their enrolled members from Medicare Advantage, Managed Medicaid, and again, qualified health plans who are seeking individual and who offer individual and small group coverage. But, are the activities we're doing in the industry today around risk adjustment missing the mark, right? I mean, providers play a very important role in risk adjustment, and health plans depend on providers to help ensure risk adjustment works. But more and more physicians are becoming overwhelmed with the information that's shared with them and the demands on their time. So today, we're going to hear insights from both the provider and the payer perspective on challenges and how those challenges are being overcome to achieve and engage partnerships. So really looking forward to some good conversation. Now, before we dive into our panel discussion, one more polling question. So I'd like to hear from our attendees out there if you think risk adjustment is hitting the mark. And is risk adjustment meeting its intended goals? And we've given you a range here to work with, so you can be a little bit creative. Just a few seconds. Oh, okay. Okay. So it looks like we're at 100%. Meeting 25% of the goals. Okay, let me go. Okay. There we go. That's better. That's better. Well, very interesting results. Thank you all for taking the time to respond to that. So, Dr. Albano, this is interesting, right? It looks like as an industry, we've got some work to do in this area. Question for you. In your experience, are most physicians aware of the important role they play in risk adjustment and how an engaged partnership, with health plans, is important to help bring, key benefits to employees?
Yeah, thank you, Roxanna. It's a great question and interesting to see the attendees' response. I mean, you can see it's a bell curve distribution, right, where we have most folks don't feel like it's meeting 100% of the goals, and most folks feel like it's not necessarily not meeting any goals, but I think most are in the middle, which is interesting to see. I think to your question, a lot of our clinicians really don't fully understand, and I think it kind of aligns with what we're seeing on the screen here, is that they don't fully understand the ramifications or the impact that documentation, and especially the meet criteria that is associated with HCC coding, has on the bottom line financially for health systems and health insurers. I think there's tremendous opportunity to improve not only education, but the communication between both the clinical teams and the clinicians, and on the payer side, right? And so obviously we share a common goal, right, is to improve health outcomes and improve the health of the populations that we serve. But I think, unfortunately, we're not all on the same page when it comes to identifying who is at highest risk for decompensation of their health, who may be considered more chronically ill compared to others, and then how do we then allocate the resources and capital needed to improve those health outcomes, or to slow the downward trajectory for those folks with, unfortunately, advanced chronic disease. And so, to your question, I feel like there really is a tremendous opportunity to improve education and communication, but I also feel like there's a tremendous opportunity to alleviate some of the administrative burden that we're seeing on our clinical teams and clinicians. And I think that the integration of AI and other software platforms will help tremendously in aggregating data and then making more educated or informed recommendations around HCC and risk-adjusted scoring.
Very good. Well, thank you for that perspective. Yeah, and we've made a lot of progress over the last 25 years, but definitely problems still yet to be solved, and opportunity to do things, differently and better. Charlie, the truth is risk adjustment is a very complex process. And, there's a perception that health plans approach it as an exercise of collecting diagnosis codes to bolster risk scores. How is Blue Cross Blue Shield of Vermont, working to change this perception, particularly when, engaging with your network providers on partnering on risk adjustment and meeting those shared goals?
I like the question. It can be perceived by many folks as just a revenue opportunity. But here, the main constituents that we have at Blue Cross Blue Shield of Vermont are specifically members, providers, patients, and the providers. And so the best way that we can do that job is one of the things that we realize, particularly being in a rural state, many small practices, they don't always, and even large practices, may not have the tools to be able to know when was the last time they've seen a patient, what all those patients' chronic conditions are. And as Dr. Albano had mentioned, resource allocation and being able to identify all that information. So some of the things we do with our PECS, provider engagement, is to work directly with the providers. We produce some specific reports that identify a list of all their members, how many have, which members have chronic conditions, the number of chronic conditions, what they are, the last time they've been seen, and then utilizing other tools to support the providers in that information. Because the big key here is to be able to reduce some of the burden on those clinicians by providing them information that they themselves may not easily have access to. A provider may know Charlie's one sick pup, so we've got to make sure we take care of him. When's the last time you saw Charlie? Oh, not that long ago. Would you be surprised it was 18 months ago? Oh, we got to get that bozo in here. So that's the type of scenario where we are trying to work hand in glove with the provider community and the clinicians so that they are able to have more information so that they can better serve their patient population.
Very good. Thank you, Charlie. I mean, it really sounds like your risk adjustment program is really built on the premise that you're really trying to promote that patient-provider relationship. So thank you for that, and partnering with your providers on that. Thank you. Okay, so Dr. Jain, the Office of the Inspector General has identified several concerns, right, about risk adjustment practices that they believe have resulted in billions of dollars of overpayments to Medicare Advantage plans. And one of the issue cited is the data integrity problem, and how health plans, may be overusing retrospective medical record reviews to bridge the gap between what the medical documentation says and what is submitted on claims and encounters. And, the bottom line is, the medical documentation must substantiate the risk score. And this fact, paired with the increased OIG oversight, puts health plans in a very, difficult spot, right? And underscores the need for payers and providers to work together. So is the regulatory landscape helping to address this data integrity issue? How can technology help?
No, it's a great question, Rox. I mean, first, let's just look at what we're talking about here. We're talking about a risk score. I don't know about you all, but whenever I hear the word score, I'm trying to make it as high as possible, right? And certainly thinking about it as a score that we're trying to optimize, as opposed to thinking about a health index. So you're asking about the regulatory language or the regulatory landscape. It's rarely ever going to be perfect. Much of what happens on the regulatory side is a lot of horse trading, a lot of consensus building. At the end of the day, whether you're a provider or you're a health plan or you're a patient advocate group, no one's going to get exactly what they want. Now, it is what it is. And thankfully, there is an evolving process when it comes to regulatory landscape. Health plans have a voice, provider organizations have a voice. So both Charlie and Dr. Albano and their peers are going to be able to impact that. And we, as a vendor, we certainly have a voice in influencing that. But in terms of where technology can step in, you alluded to a few things where perhaps the retrospective chart review may not be as meaningful. So that might mean, it might imply that we need to do a heck of a lot more during the visit and perhaps even prior to the visit. Everything from what Dr. Albano was saying earlier about maybe ensuring and training the clinicians as to the importance of this. I always think about this as, yes, when you have a added value contract as a provider with a health plan, there's a certain opportunity, but there's also a shared liability. And what that shared liability means that you also have to invest in thinking through what are the technology pieces that might be helpful in helping reduce some of that risk that an organization might have. And that's becoming increasingly important. We know that clinicians, and Dr. Albano referred to this earlier, he alluded to it, they're being overwhelmed by the complexity of EHRs. There is a cognitive load being placed on folks. And so the technology that we would want to introduce is going to be in really three different areas. One, the clinicians need a way to aggregate information that already exists. Second, they need a way to use analytics and advanced technology, some of what Charlie was alluding to identify opportunities and to have confidence in those opportunities when they're surfaced. And the third is, right now we know from study after study that documentation in the EHR is problematic for clinicians. Can we make it a little bit of a lower lift? So without addressing all three of those concerns and then making it so that there's trust and transparency in the process. Because when the OIG or the DOJ or anyone else is going to be looking at this, they're not looking for the 99% of clinicians who are all doing the right thing, but inadvertently, on occasion, have an error. They're looking for situations where there's a systematic issue. And that's what, as a vendor, and from a technology point of view, we want to make sure that we're not leading to issues that could come up. We also want to make sure, and we can talk about this a little bit later on, that there's the basic block and tackle of just getting the right information surfaced from the system. And I will tell you that from an interoperability point of view, we have made huge advances, but I don't think anyone on this call or among our audience believes that we have true interoperability today. So we also need to be pushing for both the meaningful exchange of information at the right place at the right time, but more importantly, we got to make sure that that information is aligned to what it is we're trying to do with these programs like risk adjustment. Is it aligned to it, or is it going to cause us more noise down the road because we're giving clinicians too much information and they're not sure how to react to it? So I would suggest that we all think about this as a health index, where we're trying to do the best clinical documentation, and less as a score that we're trying to optimize in order to play some sort of game. And that might sound heretical on this call, but that's sort of the way that we might want to look at this.
Yeah, no, good points. And, you know, we are going to need to look to new ways to meeting the shared goals around risk adjustment. They're very important goals. You know, it does require partnership, and there's been some pretty dramatic regulatory changes, you know, that are coming down the line, and even a bill recently introduced to eliminate the use of diagnosis from retrospective medical record reviews. So, you know, I think getting to more perspective in programs, doing what Vermont is doing, Blue Cross Blue Shield of Vermont is really promoting that patient-provider relationship, you know, as the foundation of the risk adjustment program. Absolutely, absolutely. So, Dr. Albano, question for you. One of the quarterly 2022 surveys from the Healthcare Finance Management Association found that 50% of health systems' chief financial officers and other executives said that strategic partnerships with payers is the top external challenge. So, from a provider standpoint, what are the most significant challenges, you know, your practices have encountered collaborating with health plans when these shared goals around risk adjustment? And can you share some of the hurdles that you've overcome in, you know, helping to ensure more accurate coding, you know, more accurate documentation of a patient's health status, and more accurate billing and information sharing with the health plans that need that information in order to meet, you know, their requirements under risk adjustment?
Yeah, absolutely, Roxana. And so, as Charlie noted earlier, I think, you know, time lapses quickly, especially when, you know, we have large panels of patients that we're caring for. And so one of the big challenges that surfaces is that if a patient is going periods of time without being seen by their clinician, right, and especially in primary care, it's hard to keep an accurate picture from an HCC or risk adjusted standpoint. And so that's one of the biggest challenges that I think we could really capitalize with a better collaborative approach between, you know, the provider side and the payer side, is really to educate and improve the health literacy around the importance of, you know, regular follow-up or regular check-ins, not only with the clinician, but the clinical team as a whole, because then again, we can improve our ability to monitor, evaluate, and then obviously make any new diagnosis or treatment. And then from a documentation or coding standpoint, it's much easier to keep things current. And that kind of segues into one of the big challenges that you had asked about, is that, you know, we have, you know, not moving deadlines, but several different deadlines throughout the calendar year in terms of submission of data. And so as, you know, documentation is completed and then submitted, it can be very difficult with, you know, different subsets of the population if those patients aren't getting in before the deadline or with enough time for that documentation to be submitted, audited, reviewed, updated, and then resubmitted. It poses a significant challenge in terms of the accuracy. And as Dr. Jan alluded to, it's really not an intentional, you know, slip up. It's really something where, you know, just due to the time crunch, the volume of data, and really just playing, you know, almost like a catch up or a quote unquote firefighting, it puts us in a compromised position where, you know, we end up either undercoding in fear of you know, falling in a bad view of like the DOJ or OIG, or we overcode and we don't realize that we did it. And so I think the opportunities, you know, are really abound in terms of improving education to the patients, to get them routinely involved in their own healthcare and being stewards of their own healthcare journey. I think it'd be really helpful to have, you know, more timely input. So one of the other factors that we see with our payers is that, you know, there is a lag, right? There's a lag in, you know, when we are comparing claims data versus data that's extracted from the EMR. So it'd be really great, you know, if we adopted some of the principles or pieces that we see in, like, say, the financial sector, is that if we could get real-time information at the time where care is delivered, and we keep a more running ledger of it, that would be much more helpful in terms of, you know, maintaining accuracy for both our clinical side and certainly for the payer side. And that would help to the earlier point about meeting or exceeding deadlines. I would say meeting or beating deadlines. And then the other piece of it too is really, you know, how do we look at it in a way where, you know, we're not fighting over the same capital, right? Like where do we find a common ground around premiums and the dollars that are being put into delivering care, and how do we best allocate them to large scale initiatives that are going to be better long term for the greater good, right? So I think a lot of times we're trying to focus efforts to individuals, and that's great. I totally agree. But at the end of the day, if we can do a better job delivering care to all patients with diabetes or all patients with COPD or CHF, I think that would be such a value add, and I think it would help ultimately, help us achieve, the end goal, like I said, which is, a better population health rather than individual health.
Absolutely. Absolutely. Great points. Thank you. Thank you. So Charlie, when it comes to risk adjustment, health plans have a lot, on their plate. It is a very, very complex process to manage under. What are some of the biggest challenges your plan has faced in, working with your network providers and really trying to activate, that education around risk adjustment and their participation in the information you're sharing with them? I mean, what have been some of those challenges, and how are you working to overcome them?
The biggest pieces that we have here is being able to capture the attention within the provider's office as well as with those providers, because many of our provider community are overworked, understaffed, and we do have a capacity issue in this state. And I'm sure that's happening around the rest of the country as well. So some of the ways that we're trying to do that is with the provider engagement consultants. They do their, follow-ups. They're listening to find out what the challenges are that the providers have. We provide a lot of information, so we listen to refine those reports that are helpful so that they are more actionable. That's the biggest key. And then we're also doing a lot to support them, because here in Vermont, risk adjustment is in its infancy. I know risk adjustment's been around since the late 1990s. I've been involved with PIP DCGs before we started with this version of what we're doing here. But the issue here is because it's new in Vermont on a large scale, so we've provided a lot of information with tip sheets for coding. We provide webinar educational services, both for providers, and we're trying to make sure that they can get CEUs for those, as well as their office staffs and coders. And we've been very richly blessed to be able to work closely with the AAPC chapters here in Vermont. So all of that has been helpful. And then the other big thing to try to reduce the burden for some of those providers is one of the things that we realize is that providers submit claims to get paid. They don't supply a claim to give us the complete medical picture of a patient. That means that if they can get, 2 diagnosis codes on a claim, they get paid, that's it. So what we're trying to do in supporting those providers and reduce a burden of medical record retrievals for their staffs is working with them to ensure that the number of diagnosis codes on a claim are complete, because there are many ways, we call it the leaky bucket, many places along the way, from the patient coming in with 12 diagnosis codes to only 4 ending up being on a claim type thing. There's lots of spots where it could drop off, as well as the fact that we work with our providers for remote EMR access so that we can do a lot to support them, because if it's in the medical record and it doesn't come through on the claim, if our teams behind the scenes can support them in capturing that information, then there are fewer medical record requests that have to be made. That is a way to try to reduce the burden on the providers' staffs. And internally, we have collaboration meetings where we talk with various departments within the organization that are pulling medical records and trying to share that information. So we're asking a provider's office once for a patient's medical record when possible, so that it can be shared if it's been pulled for prior authorization, for claims, for risk adjustment, for HEDIS work, other quality or disease or case management aspects. We don't want you to get, case management asking for a record today, tomorrow risk adjustment comes in and asks for the same patient's record, and then quality comes in for disease management program the day after that. That sounds silly, But the idea is you have 6, 7 departments or more looking for the same medical record on a patient. We're working internally to try to make sure we can share that information. So those are some of the ways we're trying to reduce those burdens, because the biggest issue, providers and their staffs overworked.
Yeah, very good. Thank you, Charlie. Dr. Albano, follow up to Charlie's question, because obviously, Blue Cross Blue Shield of Vermont, his plan there, like many other plans, are investing a lot in, trying to provide provider support resources, right, to help address some of this. How receptive do you think providers are to these resources health plans are providing? Are they really viewing them as a help? Are they being effective? Are they finding those resources helpful?
Yeah, that's a tough one to answer, Roxana, because I feel like anecdotally folks do welcome support, right? Certainly do. But I think at the end of the day, if it's tied to more tasks, it can be kind of counter favorable, right? And so that's where it's really, how do you frame it in a way that the support is there to actually make a difficult job a little less difficult. And I think a big part of it is really expanding out the work away from just the clinician themselves and out to the broader team. And so, as Charlie mentioned, we have a large group of folks that are doing work behind the scenes to try to help offload our clinicians and our frontline clinical teams. But I feel like it's almost an impossible task to keep up with, because there aren't enough personnel that we could hire and train and deploy to do that. And so that's where I think, it is helpful to have incentives, right? It is helpful to have support. But I think at the end of the day, if we're really going to make meaningful change, we have to start thinking more abstractly as to what really needs to be done, what needs a human touch or human element, and what really can be automated, right? And I think that's where we're really approaching that in the healthcare space, which is very exciting, right? Just the integration of generative AI and some of the other platforms that are coming out now is really, how do we make the work more meaningful and a little bit easier, knowing that it's very difficult to say the least, but we have to take that burden off folks, because regardless of the incentives and the plans and the support, I feel like it almost becomes an insurmountable hill to climb unless we're really making large scale reductions in the volume of work. And I think the only meaningful way we can do that is real full grade implementation of technology. The other thing I would suggest, and I know, depending on which EMR you use, et cetera, I think we need to do a better job from a portability standpoint, in that if a patient interfaces with the healthcare system I'm employed with versus a neighboring one or one out of state, like say in Vermont, we need to know that everybody's working on the same thing, right? So that way, it's not that this is a Charlie and his team's problem, or this is Dr. Albano and his team's problem. It's really more of a collaborative effort to really best identify the needs of the patient, the chronicity of disease, the severity of disease. And in that way, we really can create an accurate picture that does tie and associate well with the necessary funding, the resources, et cetera, because otherwise it feels like we're, I don't want to say it's a zero-sum game, but it's hard to argue against that as we move forward.
Very good. Very good. Well, thank you. Well, and we're all in this together to try to solve this problem, right? And to reach those goals. So it's really good to hear, both perspectives, because, everybody is in this together and we're trying to solve this. Well, we spent a lot of time talking about the cognitive overload, right, for physicians and what they're dealing with. And Dr. Jain, wanted to ask you, we heard both from Dr. Albano and Charlie. They both spoke about, providers are busy. They have a big administrative burden. We don't want it to divert their time from patient care. None of us want that. In your experience, how can we achieve the goals of risk adjustment and reduce this cognitive load, and to really help reduce that administrative burden? You've got a lot of experience in bringing technology solutions to the market. How can technology help?
Yeah, no, it's a great question, but I think like most things, technology is not the immediate answer. The first step, and both Dr. Albano and Charlie alluded to it, is aligning the incentives. It's the people, process, and the governance around it. And then you can bring in the technology. To give you an example, I think Dr. Albano mentioned that if clinicians knew that what they were doing would bring more money to their practice to deal with the most complex patients, and that it was actually going to transform their practice, then they might be more likely to get involved with going above and beyond the coding necessary for that particular visit and add additional codes in order for the health plan and the provider to have a much better experience of how those premium dollars can then be used downstream. There has to be an aligned incentive where both from a governance point of view, they see the need. And I would then also focus on thinking about the broader goal of improving clinical documentation. And then as a byproduct of that, the risk adjustment goals can also be met. So if you have a patient, for example, that you're seeing for a skin infection, cellulitis, many times clinicians will say, yeah, but I put it in my notes. The patient clearly has diabetes. They have an elevated A1C, but why do I need now to go through an extra step of putting that code in the billing record and so on? Can't someone else do it later? Well, they have to understand now that no one else can do it later. They need to do it at that moment in time, because all the other decision support springs from an accurate set of medical conditions. And that if we know how many diabetics we're managing, we can support a diabetes management program much better. These are the kinds of things that I think we have to get people, sort of the processes that they go through, the governance together, and then you can bring in technology interventions. Like, what do I mean by that? Well, we know that through multiple studies, and I kind of alluded to this earlier, clinicians spend a lot of time hunting and pecking for information. So if we can make that a little bit easier, maybe we can reduce 66% of the time that they're spending in the EHR. We also know that many clinicians, and I'm sure Dr. Albano is probably one of them, I certainly was, that we do a lot of work during the day, and then we go home, have dinner with the family, and then in the evening, we're finishing up our documentation. So can we actually create a model that supports the goals of risk adjustment while at the same time supporting the true needs that they have around clinical documentation, generating the documentation? Everything from using natural language processing to advanced analytics to traditional AI to generative AI, where we can start to not create net new evidence, but take what's already there and synthesize it in a way where the clinicians feel like, wow, I'm able to not only support the documentation needed for this code, but I'm also able to continue my note. And now when I send my patient to a referring provider, they're able to get a much more comprehensive understanding of my patient. I think the most important thing we can do is not make this only about technology, but it's about aligning the goals that the providers have with the goals that health plans have, and saying, how can we start to fund this? Technology comes in to make that whole process more efficient, but it's not going to be the panacea that the providers and the health plans need in order to collaborate. It may be a strategic vision that a vendor can bring to the table, but ultimately it's going to have to be individuals who are practicing differently in a way that reduces both the cognitive load that comes from the technology, but the cognitive load that comes from always feeling like they're not getting the resources they need to be successful in their practice.
Yeah, very good. Very good points. Excellent points. So Dr. Albano, Dr. Jain just went through, a number of, concepts that can really help address this administrative burden for providers. Is there one or two emerging that come to your mind that you think will really help align incentives and really help address that administrative burden? I mean, are there like top things on your list that, I really think this holds a lot of promise?
Yeah, Roxana, Dr. Jain brought up a lot of great points. I think in my mind, financial incentives only motivate for so long or go so far. I look at, time is it's the resource that we can't renew, and it in my opinion is the most precious. And so, as Dr. Jain was pointing out, for folks to be able to finish their clinical workday and be able to really, close the EMR, not tap back into it. Obviously, if they're on call, that's a different story, but to really go and disengage from that work to get back to recharge their battery, whether that's pursuing a hobby, spending time with family, et cetera. I feel like that's really the missing link that we're really trying to capitalize on. And different initiatives that we're looking at are really, optimizing medical documentation, right? So getting the progress note and other clinical documentation back to its core principle, which was to track change over time, right? To say patient presents with X complaint, intervention is introduced, follow up to see how patient responded to intervention. With the advent of remote patient monitoring, we probably can cut out some of the pieces of that puzzle, but the end goal is really to say, how do we distill everything down to its basic tenets and then fold in pieces of information that are needed from the billing and coding side, so that clinical documentation doesn't.
Did we, I think we may have had a pause on Dr. Albano.
Standpoint. So, we fold into it, what are the most appropriate HCC diagnoses for the patient and what's being done about them? Do we have any outlying care gaps, right? So when we think about preventative strategies, how do we fold those into it without becoming a distraction to the principle or the purpose of the encounter? And then certainly we use the team around the clinician. So whether that's a physician or an advanced practice clinician, what we're doing is trying to leverage teams either behind the scenes or at the elbow to try to help in achieving that end. And so those are some of the initiatives that we're really looking at. I think, as Dr. Jan clearly articulated, there's a lot on the horizon in terms of what other resources are available to us. And I think one of the big pieces that I don't think we've really fully capitalized on yet is the patient entered data. And I think that's going to be instrumental in helping us not only keep a more accurate picture from a risk adjustment standpoint, but really help to cut out some of that time that we were waiting for from a trial and error standpoint in terms of medical management, to really say, how is the patient responding to therapy, to all the interventions, and being able to make near real-time adjustments. So that way, when that patient does ultimately follow back up, we know that they're on the right track or the right trajectory. And hopefully all we're doing is just, keeping them on that trajectory for the long term.
Excellent points. Excellent points. Thank you. Thank you. Okay, so we've had some really, really good insights shared. We want to pause for a moment and we want to hear from our audience. We want to hear some thoughts. We've talked about some challenges. We've talked about some new strategies. Want to hear from our attendees to see if these are challenges that you're dealing with, and if so, what are your top three? We talked about the need to get away from reliance on retrospective medical record reviews. It's hard on the health plan. It's definitely hard on providers that get hit with these large requests at the end of the year, and moving toward more prospective programs that really promote that patient provider relationship. We talked about needing to meet providers where they are, right, and engaging them in their daily workflow. We talked briefly about aligning financial incentives and more efficient exchange of clinical documentation. So which one of these challenges do you guys out there attending consider your top three? There you go. Aligning financial incentives and limited time. Those are the big ones. Those are the big ones. Very good. Very interesting. Excellent. Thank you. Okay. I think that would pretty much complete. Very good. Okay. So Charlie, in closing, what lies ahead for you and Vermont? What are some things you guys are looking toward in the future, that you feel may help you, or that you would like to pursue to help you in your partnership with your providers on risk adjustment?
I think it's the continued opportunity for open, honest dialogue and making sure that the providers do see us as partners in helping them some of the things that can be done, as knowing that we're here to support them in their patient care. It is through the use of the dollars. It gives us the opportunity to enhance benefits so that maybe, if members have a richer RX program, they may be more compliant, and that helps both the member and the providers as they move forward. as well as developing additional programs to help if providers, we see a large number of providers having a patient panel with this kind of a consideration. One of the things we're talking about internally is a team approach where there is the case management and risk adjustment teams working directly with those provider communities, each of those provider groups, so that they have a direct linkage to someone specific if that works to support their needs for them in an office setting as well as for their patient population. Thank you.
Very good. Thank you, Charlie. And Dr. Jain, these survey responses, any surprises here, any comments here on these? And, you know, in addition to that, you know, as you look ahead on where the industry is going, where CMS is going, you know, and the responses we have from the attendees, what do you think is, you know, lies ahead that will be the most disruptive item that can really, you know, change the way payers and providers engage, you know, around these shared goals?
Yeah, I don't think there's any surprises. I think if you had asked them to, you know, instead of the top three, ask them what their challenges are, they would have marked all of them because they're all a bit of a challenge for different folks. But you almost made a Freudian slip. Instead of saying disruptive, you almost said destructive. And I think that's an important thing to consider. And that, you know, when you start thinking about what we're hearing from the OIG and DOJ, some of the examples of some of the audit risks that are out there, and we kind of alluded to it earlier in our conversation around, you know, the challenges and maybe the hazards of retrospective reviews. I think there's going to be a greater emphasis placed at the point of care in that visit and everything that has led up to that visit. And what is it that we're going to do in collaborating between health plans and providers to provide as much support for that provider as possible, getting them the information that they need? Because whether it's the health plan sending a reminder 3 weeks later, or whether it's an addenda that is loosely placed in the chart, or whether it's a problem list that looks like nothing that I actually did to take care of that patient, these are all going to be issues that are going to be, and by the way, I'm not a lawyer. I hope you all understand that. So whatever I'm saying based on what my interpretation of some of the challenges are. We're going to have to pay much more closer attention to the link between the actual care that's being provided for the patient and the process by which we document and use that information to actually guide that patient's care. I think Dr. Albano referred to this as what are we actually doing to take care of that patient? And I feel pretty strongly that if it's purely an artifact that the clinicians are going to be asked to support, it's not going to work. There's going to be liability associated with it not working. There's going to be financial penalties. I think about some of the recoupment that OIG might ask for to give back money that providers have been enjoying or expecting or have funded their program. So getting it right is going to be really, really important. And some of these disruptive or destructive, however you want to look at it, advances may be necessary. I'm not a regulator and I'm not a lawyer, but I think providers and health plans are going to have to figure out how do we provide some TLC for the providers at the point of care and just immediately before to provide the most optimal outcomes. And I love what Dr. Albano said about the patient's involvement. How do we get the patient's involvement in there so that perhaps that clinician team, the nurse, the provider that are taking care of a patient, their jobs could be a little bit easier and more meaningful when we're actually hearing from the patient. But I think as a whole, I worry a lot about the unintended consequences of the audit process and what it might mean for that collaboration between payers and providers. And it's not going to be business as usual from what I see and what I read, but we welcome other perspectives on that.
Excellent. No, very, very good points. Well, we are 10 minutes to the end of our discussion today. So I'd like to just pause now and open up the session to some questions from our attendees. I want to thank all three of our panel participants for your excellent insights. It's been a great discussion. I want to begin with this question because I just love this question. I think it's a great one. As prevention proves to be successful in reducing risk, how does the system reward the clinician for that success? The risk score will drop. Do you pay for that and then pay to keep that constant? Or does that disappear until new patient comes in and the doctor can be paid to reduce that patient's risk? It is a very interesting question. Any thoughts on that?
Yeah, I'm not sure who's supposed to go first, Roxana, but I'll jump in. I love the question. I think, it's kind of one of those things where how do we get away from the RVU model or the transactional model that we're so accustomed to, and to really start thinking about how do we best use the capital allocated to care for patients and really use as little of it as possible, right? And I mean, that in and of itself is a loose definition of value-based care. And so the way I would look at it is that, do we tie a certain amount of dollars or capital to preventative strategies? And we say that, on average, right, we would say that the average risk person, this is the expense or the cost to care for them and to keep them at average risk and keep them healthy over time. Obviously knowing that things can change in the future, but hopefully if we're doing our jobs well and the patients are fully engaged, then hopefully we'll keep them on a very favorable path. But I think ultimately there needs to be a pool of resources, right, to help keep those patients healthy. And then I think we need to really be shifting towards the mindset of how do we use as little of that pool as possible from a preventative side. And then hopefully, we'll have some, I would say, again, I'm not an attorney either, but if I were, I think about like, how do you put funds in an escrow account or some other account that could be siphoned off and used for, the deviations from the baseline, of health, right? And then from there, you could hopefully redirect the patient back, right? So if there's acute illness or injury, you remedy that and then put them back on the pathway for wellness. I think in the current model, all we're really stuck with is really this more transactional interaction, right? To say that, we're doing our best to keep you healthy, but the incentive model doesn't really drive that as much as it does to episodically care for you. And so that, I mean, it's going to take a tremendous shift in our mindset and our culture kind of expectations for us to get there. But again, I love the question. I think it really has to be this, a big drive towards value-based care, value-based reimbursement, and really a pooling of resources that best suits populations of folks and not just, piecemeal individuals in their healthcare journey.
I think
Absolutely. There lies the promise of value-based care, right?
one thing I'd like to add to what Dr. Albano said is that I think in some of the work that we do around preventative care should be washed out with the quality measures. If you're measuring the different gaps in care and quality measures, preventative screenings, mammography rates, colonoscopy rates, and you're holding plans accountable to that, perhaps this is another area of collaboration between the health plan and the provider groups to make sure that these preventative care strategies are well funded. Because there is a financial impact if we don't get the preventative services done right.
Very good. Excellent. Thank you. Charlie, question for you. What are providers doing with the reporting?
Absolutely.
You're
I think
supplying them, and how do you ensure that they're utilizing it?
Provider engagement consultants have regular follow-ups in working with the providers, and we've tried to make those reports actionable by highlighting specifically what we call members without office visits. So the clinicians have a rank order of the members by the number of chronic conditions. We're not sharing. We're just saying quite simply, because I'm neither a clinician, nor a coder, nor a lawyer. So the idea here is to be able to say, hey, doc, you have, 500 patients in this, practice. Here are the number of patients with chronic conditions. Of those, how many have 5 or more, 3 or 4, 2 or 1 chronic condition? So that they have that list. With the PECs going out and speaking with the providers, and I'm encouraging the PECs to be able to reduce the number of members that are very high risk that have not yet been seen year to date. And so that's the way we're trying to follow up with the providers and their office staffs and support them in making sure that those members are outreached so that they can be brought in for care. And it's most important to start those activities early in the year so that they have that opportunity to get those members in. At this point in time, as we said, access is very, very tight in trying to get members in. The docs probably have very few, if any, opportunities to see a patient between now and the end of the year, particularly with holidays and things of that nature. So we really do follow up with the providers, listen, let them and their staffs know, because they are an extension of in helping the provider in many other ways to get that information done. I hope that's helpful.
Yes, thank you, Charlie. Dr. Albano, I think this is probably a good question for you. Whatever attendees want to know, how do you educate your providers on risk adjustment and the financial impacts?
I would say the immediate answer is very carefully and repetitiously. But I would say that the broader answer is, we have kind of a multimodal approach, right? So we certainly try to provide at the elbow support for folks that would likely benefit the most. And so you think about it as, maybe the late adopters to some of our change strategies. We also conduct webinars that we videotape and also hold live that folks can watch during the lunch hour or watch at their leisure. We do send out print communication, via email and kind of monthly updates. So again, it's a multimodal approach because obviously, with adult learning, everybody has a different perspective and strategy, and I think repetition really is key. But I will tell you that, there isn't a perfect solution in terms of education. I think a lot of it is just identifying, and this is something we're actively working on. I mean, I was in a meeting last night. We're trying to actively identify who would benefit from which approach, knowing that we don't have enough folks to do at the elbow support for everybody. So how do we, really partition who would benefit from the folks at the office with them, who would benefit from more passive engagement, and maybe some folks that maybe fall in the middle where they get less frequent at the elbow support and more asynchronous communication and education. But yeah, I would say at the end of the day, it's an evolving process and one that we're continually learning more about as we move forward. But I think a multimodal approach is really the best strategy I have right now.
Very good. Well, thank you. Thank you. Well, I'm looking at the time. We have more questions, but we're running out of time. And I'm going to wrap up now. And I just want to thank all three of you gentlemen for joining us today and sharing your insights. Really appreciate it. A big thank you to Becker's for, coordinating, sponsoring this discussion. And thank you to the folks that attended. Hopefully you saw this as insightful, a good use of your time. So with that, I'm going to turn it back over to the Becker team to wrap up our discussion today.
Thank you so much, Roxana. That is all the time we have for today. But we want to thank our presenters for an excellent discussion and Innovaccer for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.